interval after the missed beat. This is the missed beat. This is the time where there is a missed beat. So if you look at the PR interval in the ECG of the patient with after the missed beat and before the missed beat, like let me put pointers here, this is totally asymmetrical. So if you notice that the PR interval before and after the missed beat is asymmetrical, then it is gonna be Moubert's one heart block, that is known as Fmge phenomenon. I'll have to put the pointers again. This is the PR interval beginning of P to the starting of the Q wave. And then if you look at the PR interval here, there is definitely some difference, pretty appreciable. This is a P wave, this is T, this is a P wave, and then we are having a missed beat. There is no QRS complex occurring here. So if you look at the PR interval, which is gonna be before and after the missed beat, there is a asymmetry. The one before is relatively more and the one after is relatively lesser. So this asymmetrical PR interval, it is always diagnostic of Moubert's one heart block. But if you come back to the previous slide, you will notice the fact that in this particular recording, what is happening is that this was P, then there is a missed beat. If you look at the PR interval after and you look at the PR interval before, they are almost identical. So because the PR interval before and after is identical, therefore it is gonna be Moubert's two heart block in a patient. Canon A waves. Canon A waves are read by you in two topics, VT and second Canon A waves are seen by you in third degree heart block. Well, one thing is very clear, this ECG is not that of VT, so it must be a third degree heart block. So the question is giving you a right diagnosis right away. And then you will also notice that if you look at the RR interval of this patient, and then if you look at the PP interval of the patient, it is not equal. This is the RR interval. This is the PP interval. PP and RR interval should always be equal. But if PP and RR intervals are unequal PP and RR interval is always diagnostic of third degree heart block. So answer to this question will be given as C. This I've already explained to you. We can just have a look at it. Patient develops missed beats after thrombolysis for MI. So after MI anyway, remember the bradyarrhythmia that develops commonly after MI is Moubert's two heart block. So I mean the diagnosis is made most of the time on clinical grounds only. And this is P wave and then there is no QRS complex happening. If you look at the PR interval before and after, the PR interval before and after the missed beat is equal. So it is Moubert's two heart block. In the following slide, I have tried to compare the three first degree heart block versus Moubert's two heart block. You see in first degree heart block, the PR interval of the patient is prolonged, but there is no drop beats in a patient. That the PR interval is always on the higher side. So PR interval will usually be in excess of 200 milliseconds. That would be 5 small squares in the ECG, but you will not have any drop beats. But if you have is a increase of the PR interval, if you compare these three PR intervals, you can see a progressive lengthening, and then you can notice the fact that P wave is coming and there is no QRS complex. This indicates that there is a Moubert's one heart block. Moubert's two heart block, the PR interval before and after will be equal in amplitude. Before and after would be equal in amplitude. This is the time where there is a missed beat. And in third degree heart block, you will notice that the RR interval of the patient and the PP interval of the patient is not equal. That would be diagnostic of third degree heart block. Broad complex QRS is also encountered here. What is the location of the ERS point during auscultation? ERS point is for evaluating splitting of the second heart sound. And splitting of the second heart sound is best heard in this area. That would be part number C of the discussion. That would be left side third intercostal space. Now answer would be C, third intercostal space, left parasternal line in the patient. Second heart sound in a MCQ can be asked as either wide split or narrow split. For wide split, there could be two possibilities. Either it would be variable split or it could be fixed split. Variable V for victory, remember, is seen in VSD, that is beginning with V and mitral regurgitation. Fixed split. Wide fixed split is encountered in ASD. Instead of writing ASD, the MCQ can write the word Holt-Oram syndrome, or the MCQ could write a term where there is ASD present TAPVC, or you can write a condition where ASD with mitral stenosis is present, that is known as Lutembecker syndrome, or he can write the word pulmonary embolism. Whereas narrow split second heart sound is a condition that is always encountered with respect to valvular aortic stenosis, hypertrophic cardiomyopathy, and left ventricular failure. For left ventricular failure, he might write the term beriberi. For left ventricular failure, he might write the word severe anemia. The concept is that whenever you are having any obstruction or failure of the left side of the heart, blood will take longer time to go out, so aortic valve will close late, and if aortic valve closes late, there is a narrow split second heart sound. So remember the data for the wide split second, V variable, VSD pretty straightforward, ASD fixed everybody knows. So I would like you to remember the inferior data, Holt-Oram, Lutembecker and TAPVC with pulmonary embolism, and for narrow split it is obstructive events or failure of the left side of the heart. An athlete collapsed suddenly during exercise and died. The post-mortem shows the following image. One, you can notice very significant asymmetrical, there is a very significant asymmetrical hypertrophy of the septum. This area, this is the septum area, it is hypertrophic. Then the cavity of the left ventricle, this is banana shaped cavity of the left ventricle. There is a hypertrophy of the free wall of the heart. Now why this is not aortic stenosis? Why it is not aortic stenosis with left ventricular hypertrophy? Because aortic stenosis with left ventricular hypertrophy will not have a septal involvement. Septal involvement is not seen in valvular aortic stenosis. Septal involvement is always a feature of HOCM, asymmetrical septal hypertrophy. Why the answer is not mitral stenosis? Because mitral stenosis will cause right ventricular enlargement. In this image shows left ventricular enlargement. Right ventricle is here. That looks pretty decent. Mitral regurgitation, well, why is not the answer? Because mitral regurgitation will cause left ventricular failure, not hypertrophy. So one, the question is mentioning about an athlete dying suddenly, so we are thinking in terms of a hypertrophied heart. And out of the two options A and D, the correct option is HOCM, which is primarily because of the fact that there is a asymmetrical septal hypertrophy in the patient and a banana shaped cavity of the left ventricle. Drug of choice for management hypertrophic obstructive cardiomyopathy is propranolol. To prevent the chances of sudden cardiac death, implantable cardioverter defibrillator should be used. The treatment of choice for management of these patients would be to go in for alcohol-based septal ablation, which will help in quick management of these patients. This is one medical condition where nitroglycerin is contraindicated. There have been deaths in football matches with respect to hypertrophic cardiomyopathy. This slide just shows that. So never give a medical certificate to somebody with a narrow split second heart sound and pulsus bisvariance. Pulsus bisvariance is an auscultatory finding of hypertrophic cardiomyopathy, and sudden death can definitely occur. There have been instances even in international games. You can see the Argentina jersey behind. A 22-year-old footballer, he died while playing, and ECG was done in pre-tournament health camp, which ECG finding was missed, resulting in death of the footballer. So we did a health scan of this patient before the game, but he died in the football game. This finding that is mentioned here, this is at the end of the S wave. This is known as epsilon wave, which is diagnostic of arrhythmogenic right ventricular dysplasia. You see, nowadays, because the genetic testing for HOCM has become common, hypertrophic obstructive cardiomyopathy can be easily identified with beta myosin gene testing. Beta myosin gene testing is regularly done on football players to identify HOCM nowadays. So therefore, the current edition of Harrison says that the incidence of HOCM causing football-based deaths has reduced because this testing is available now. Another cause is becoming a predominant cause of death in football players, that is arrhythmogenic right ventricular dysplasia that is causing epsilon wave. Commotio cordis. If there is blunt trauma to the chest, you can see a straight punch to the chest of the patient. Commotio cordis can cause asystole and can cause death in a match where body contact sports are being followed. So remember the fact that commotio cordis or direct trauma to the chest can result in development of asystole in the patient. Death in an athlete. We have discussed two possibilities here. One of the reasons why an athlete can die is due to hypertrophic obstructive cardiomyopathy. But with beta-myosin gene testing available, it is less likely to be a cause. Another cause is arrhythmogenic right ventricular dysplasia, which can be evaluated on the basis of epsilon wave. Another cause that has to be thought of for sudden death could be commotio cordis, where there could be a blunt trauma to the chest of the athlete and the heart will develop asystole. But still there is sudden death in an athlete during vigorous exercise. Then what can happen is that because these athletes are having a very significant left ventricular hypertrophy, the left ventricular hypertrophy can cause compression of the coronary artery. During vigorous exercise, there can be compression of the coronary artery, and the compression of the coronary artery can result in MI in an athlete. So during extreme exertion, like I would say mountain biking, like rock climbing, there is a possibility that when the athlete is pushing the limits of athletic capability, the enlarged heart might crush its own blood supply and might result in death of the athlete. The most common cause of death in athletes is not HOCM. You see, HOCM people normally will never reach that athletic level of being a super athlete. So don't be under impression that at a club level HOCM would be causing a death. The following diagrams here represent chamber enlargement. If you look at the diagrams here, you would be getting a better orientation with respect to the fact that the right heart border, if this is the image, you can just look at it. This is the aortic knuckle. This would be the right atria of the patient, the superior vena cava and the inferior vena cava. This would be the aortic knuckle. Then would be the main pulmonary artery. Then is the left atrial appendage, and then is the left ventricle. Left atria is situated posteriorly and does not form the left heart border. And the right ventricle is not on the right but is inferiorly located. Right ventricle does not form the right heart border. To complete the diagram, this would be the aorta. This would be the aorta originating from the left ventricle of the patient. This would be the pulmonary artery originating from the right ventricle, giving rise to two branches. The objective is to explain to you the fact that if in the patient left ventricle will become bigger, then this particular apex of the patient will be displaced downwards and laterally. Whereas if the right ventricle of the patient will become bigger, then the right ventricle will tend to push the apex superiorly. So if you have a apex beat of the patient which is displaced downwards and laterally, then apex beat that is pushed downwards and laterally, it indicates left ventricular enlargement. Whereas if the apex of the patient is pushed upwards and laterally, it indicates a right ventricular enlargement. So enlargement of the left and the right ventricle has been asked. That is why this image is there. Okay guys, as you can see in this particular representation, the cardiothoracic ratio of this particular patient looks normal. But if you compare with the image on the right hand side, you will notice that the cardiothoracic ratio, the cardiac size is significantly enhanced. You will also notice that there is a inferior displacement of the apex of the heart. You can also notice in the representation these perihilar infiltrates. extending up to the periphery. There is also some evidence of minimalistic pleural effusion present in the patient. So considering the image showing an increase in cardiothoracic ratio, perihilar infiltrates, it is suggestive of left ventricular enlargement, and the image also shows evidence of pulmonary edema. So this goes in sync with the fact that the left ventricle of the patient is enlarged, and this image, it shows a left ventricular enlargement. In contrast, if you look at the subsequent image, this one, you will notice the fact that when the right ventricle will get enlarged, then the enlarged right ventricle will result in development of pushing of the entire left cardiac border. So the apex of the patient is rather lifted upwards. As you can see in the figure, when this will enlarge, this enlarged right ventricle will be pushing the entire left ventricle upwards. So this image will basically be representative of right ventricular enlargement in a patient. The same is represented even here. This is normal cardiac waistline. But then you can see that since the right ventricle is inferiorly placed and it is getting enlarged, it will affect whole of this cardiac border, and therefore there is a superior displacement of the heart of the patient. That is a straight cardiac waistline that is developing in the patient. For the left atrial enlargement, left atria is situated posteriorly, so it will mainly affect the carinal angle. You can see that the carinal angle is the one which is usually getting affected. This normal carinal angle would be something between 60 to 70 degrees. So in this image, as you can see that the carinal angle will get relatively widened. Then this will also push the right atria of the patient, and there will be a double atrial shadow. There would be a double atrial shadow developing in a patient. The reason for double density is based on the fact that it is the enlarged left atria that is pushing the right atria of the patient. This is normal carinal angle, as mentioned here, 60 to 70 degree. And in the subsequent image, as you can see, the carinal angle is relatively widened. Double density, as I've highlighted, is because of the enlarged left atria pushing the right atria. This is representation of the left heart border. Right atrial enlargement. The image here shows only a right atrial enlargement. If you look at the previous animation, you can see that this is the right atria of the patient. So when the right atria will become relatively bigger, it will push the right heart border itself. That is represented in this particular image. So coming to the next question, the previous representations were mainly for the cardiac enlargements in the patient. What I have taught you is left ventricular enlargement, right ventricular enlargement, left atria, and right atrial enlargement. Left atrial enlargement, mainly remember that the apex of the patient will be displaced laterally and inferiorly. Right ventricle, the apex of the patient will be displaced laterally but will be displaced superiorly. Left atrial enlargement will have two findings. One would be increased in carinal angle, which normally is 60 to 70 degree. And the second finding would be a double atrial shadow or double density. For the right atrial enlargement in the patient, remember that the right cardiac border will become relatively more prominent. Coming to the next question, a short stature female presents with history of wearing socks in the summer season, and physical examination of her shows icy cold toes with cyanosis. When I say this fact that she is having icy cold toes with cyanosis, I mean that she is having peripheral cyanosis, and then she is also short stature. Then if I look at the X-ray, I will be able to notice specifically the notching of the lower border of the ribs. This inferior notching of the ribs is the key in the question. Inferior notching of the ribs is a characteristic feature that is seen in coarctation of aorta. You see, short stature probably implies that this patient is suffering from Turner syndrome. In patients who are having coarctation of aorta, there will always be a development of decreased blood supply to legs. This decreased blood supply to the legs of the patient and decreased blood supply to the toes of the patient will explain the fact that the patient is wearing socks in the summer and there is icy cold toes with cyanosis. The cyanosis is a peripheral cyanosis. Why answer is not hyperparathyroidism? Because in hyperparathyroidism you would be having rather symptoms of abdominal pain, you would be having metastatic calcification, and most importantly you would be having notching of both superior and the inferior border of the ribs. Neurofibromatosis 1 or neurofibromatosis 2, they will always be having findings of cafe-au-lait macules, which is not given in this question, axillary fleckling. There could be a presentation of optic glioma present in the patient. So none of the neurological features are present. Multiple myeloma, well, unlikely in a female with, okay, the age is not given. So multiple myeloma presents with lytic lesions that are more common in the vertebra, then in the pelvis, and then in the skull of the patient. So here we are not having any lytic lesions, but it is inferior notching of the ribs. So pretty straightforward a question. The answer would be given as coarctation of aorta. I would also like to say the fact that if this is the representation of the ribs, this is another rib. Just inferior to the rib would be the blood vessel by the name of intercostal artery. This intercostal artery will function like a collateral, and what will happen is that when this artery will get dilated and tortuous, then the pulsations of the artery will start damaging the lower border of the rib. In representational purposes, what I have shown is that this is the representation of the intercostal artery. In patients who are having coarctation of aorta, the intercostal artery will become dilated and tortuous. So because the intercostal artery will become dilated and tortuous, the pulsations of the intercostal artery will cause damage to the lower border of the rib, which is responsible for what we read as inferior notching of the ribs. This will always help in diagnosis of coarctation of aorta, which will result in development of hypertension. Chest X-ray was done for a 15-year-old boy with a low cardiac output. What is incorrect about the patient? If you look at this X-ray, one, you will notice that there is a straightening of the left cardiac border. Straightening of the left cardiac border is a feature that is encountered in mitral stenosis, especially low cardiac output, and then mentioning the age of the patient. This suggests that there could be a rheumatic etiology behind development of this mitral stenosis developing in a patient. First option is reverse split S1. You see, in mitral stenosis, as the opening will become relatively smaller, the blood will take more time to go across. So transit of blood in patients of mitral stenosis from the left atria to the left ventricle, because the opening is smaller, so transit of blood will take always extra time. And if transit of blood will take extra time, therefore the mitral valve of the patient will close relatively late. And when the mitral valve of the patient will close late, then the significance of mitral valve closing late will be that suppose we represent first ultrasound as M1T1. This is mitral valve closure and this is tricuspid valve closure. Because in this patient mitral valve will close late, so I'm shifting this dotted line slightly to right, and this will represent the fact that the gap between the two will become less. And if the patient will have progressive lesion, then mitral valve will close so late that both might be starting to close at the same time, and we will have a single S1. And if in a patient the lesion is progressive, then we might even have a situation where the mitral valve might close so late that it will close after the tricuspid valve. You can see in this representation, I have first tried to show that the mitral stenosis patient could be having is a presence of narrow split first ultrasound. Then the mitral valve will close so late that there will be a single S1, and then there could be a possibility that patient could be having a reverse split first ultrasound, that is T1M1, which is tricuspid valve will close on time, but mitral valve is closing so late that it is closing after the tricuspid valve. So first statement looks decent, okay. Straightening of the left heart border, very visible on X-ray. Caricum's murmur is a characteristic murmur of rheumatic etiology. Seagull murmur, well, that's a murmur that is seen with mild aortic regurgitation. So because the question is saying incorrect, therefore the answer to question number 22 is delta, that is seagull murmur. The image here shows straightening of the left heart border. Double density is not very visible. Trachea central in this patient. The image is primarily trying to highlight the I would say like this, that the image is trying to highlight that normally in the left cardiac border we have is this curvature, which is that aortic knuckle is convex. But the next area after the aortic knuckle, this particular area is concave. This is the main pulmonary artery area. And what happens in patients of mitral stenosis is that there is fullness in the area of the pulmonary artery. And because there is fullness in the area of the pulmonary artery as well as of the left atrial appendage, so what I can do is that I can draw a line which is passing straight through all of these. So why are you having a straightening of the left heart water? That's what I'm trying to explain to you. That normally you have convexity of the knuckle and the main pulmonary artery area is concave now because there is a fullness there and fullness with respect to the left atrial appendage. That is why there is a straightening of the left heart water. Very easy to pick up with respect to mitral stenosis. Okay guys, we shall be talking about picture based questions or image based questions with respect to the topic of endocrinology, about which you would have listened to my lectures. Now, if you look at the first figure, the question says all are true about the condition shown except. So, one in this particular picture, you can notice the fact that the image is trying to show you regarding presence of Cushingoid appearance of the patient. Why are we calling it a Cushingoid appearance? Because the patient is having a centripetal obesity, which favors centripetal obesity, which favors Cushingoid appearance. Now, in patients who are having Cushing syndrome, the question says hyperpigmentation in ectopic ACTH production. Ectopic ACTH implies oat cell cancer, and because ACTH will have partial MSH-like activity, so therefore there will definitely be a hyperpigmentation that would be seen in patients who are having ectopic ACTH production. Purplish striae, yeah, because there's a very significant weight gain in the patient, so there would be purplish striae that would be appearing on the lateral part of the abdominal wall. So A and B look very decent. Hyperkalemia. The point is that cortisol in the body can behave like aldosterone. Because cortisol can behave like aldosterone, what it will do is that because cortisol will cause activation of the epithelial sodium channel, there will be a development of gain of salt and water much more than normal. So just drawn it thicker to say that more salt and more water is coming in the system, and because more salt and more water will come in, therefore there will be also a more corresponding loss of potassium and hydrogen. Now, because of the loss of potassium from the body, there would be a hypokalemia, whereas loss of hydrogen will cause loss of hydrogen would cause a metabolic alkalosis. So all patients of Cushing syndrome would tend to have a development of hypokalemic alkalosis, and therefore you can see from the discussion that I mentioned that the correct answer to this particular question would be given as C. That would be hyperkalemia, because we rather have is a hypokalemia and a associated alkalosis due to urinary loss of potassium and hydrogen. Moving on to the next question. Identify the disease shown in the image. Gigantism, acromegaly, pectus carinatum. You see, pectus carinatum should have a chest deformity. Well, there's no visible chest deformity in this particular patient. Goiter, well, you can't make out any large goiter, and goiter should be a frontal view. So, in this particular case, one I would like to say very prominent jawline in the patient. So, this goes in favor of diagnosis of excess growth hormone in the body of the patient. Considering the limitations of the image, the probable clinical diagnosis of this patient will be acromegaly. Why I did not say gigantism? Because that would be seen in children with excess of growth hormone, but acromegaly would be adults with excess of growth hormone, and the reason for acromegaly would be a pituitary adenoma. To diagnose acromegaly in a patient, if the question is asked as what is the investigation of choice for acromegaly, screening test for these patients is insulin-like growth factor 1 levels, IGF-1 levels. But the investigation of choice for these patients would be answered by you as glucose challenge test. Normally, glucose can suppress growth hormone production, but here you will be having failure to suppress growth hormone production. For treatment of these patients, the ideal method is to treat and go in for transsphenoidal surgery. Transsphenoidal surgery will help in treatment of pituitary adenoma, which in these patients, if more than 10 mm, can even cause a visual deficit in the form of bitemporal hemianopia. However, if there is a recurrence of the tumor in acromegaly, then the drug that is used if there's a recurrence of symptoms in patients of acromegaly should be answered by you as pegvisomant. If you read the name pegvisomant, somant, you see somatic growth. So pegvisomant is gonna be neutralizing the effect of the growth hormone. It is a growth hormone receptor blocker. It will neutralize the effect of growth hormone on the tissues of the patient. And in a recent AIMS MCQ in acromegaly, they had given an image of the hands of the patient. The fingers were very broad and thick, so spade-like hands. Spade-like hands is a feature that is seen in patients of acromegaly. This is because the peripheral parts of the tissue tend to become relatively bigger. So answer to this question, answer is beta, Bombay. In the next image, the question says all of the following will be seen in the patient seen below. So one, I can say that in this patient, we can see stare sign. Why I'm calling it stare sign? Because in this girl, you can see the white of the eye above the sclera. You can see prominent eyeballs. I cannot comment on the proptosis part by this image because proptosis, you need to look at the lateral part. But what I can clearly see is a stare sign because you can see that the upper part of the cornea is visible in this patient. Now question says all of the following will be seen except myxedema. Myxedema, which is seen in Graves' disease, is a pretibial myxedema. So choice A is okay. Dimple sign, yes, we do have dimple sign present in these patients. Moist warm hands here because of sympathomimetic activity. Sweaty palms, sweaty feet can be seen. But constipation is a feature that is seen in patients having hypothyroidism. So the correct answer to this question will be delta. Constipation is a feature of hypothyroidism and not of thyrotoxicosis. A patient presents with hypertension and hypokalemia. A CT abdomen was performed. What is the diagnosis? First is pheochromocytoma. Pheochromocytoma is a tumor that will originate from the adrenal medulla of the patient. This is the representation for the kidney. Superiorly, you can see the liver. But this lesion is above the pole of the kidney. This is the lesion. It is above the pole of the kidney. So this looks like a lesion present in the adrenal gland. Now he says there is presence of hypertension with hypokalemia, and what is the diagnosis? Pheochromocytoma will present with hypertension, but electrolyte imbalances are not seen. In Conn syndrome, we have hypertension and urinary loss of potassium, so there is a hypokalemia, but hypertension is seen also in patients with hypokalemia and Liddle syndrome. Now the difference between the two is that in Conn syndrome, there is a tumor causing excess of aldosterone. So once the values of aldosterone in the body will skyrocket, you would have hypertension with hypokalemia. In Liddle syndrome, it is a receptor defect. So since receptor defect will not exhibit any tumor, so Liddle is ruled out. Secondary hyperaldosteronism is like causes of secondary can be like heart failure or it can be cirrhosis of the liver. The liver looks good sides in this case. Then nephrotic syndrome can be a cause of secondary hyperaldosteronism. So considering all the options that are mentioned here, well, A and D are straightforward ruled out. Left behind is Conn and Liddle syndrome, and because there is a tumor visible on a CT scan, so the answer to this question is beta Conn syndrome. Conn syndrome is due to adrenal adenoma. Investigational choice for diagnosis of Conn syndrome would be answered by US salt loading test. Okay, a 25-year-old patient presents with weakness and craving for salty foods and postural hypotension. Lab shows a low sodium values with elevated potassium. The first statement of this question basically tells me the fact that there could be an association of aldosterone in this question. Why I'm suspecting aldosterone is because sodium in this patient is less than normal 130 and potassium is more than normal, plus there is history of craving for salty foods and postural hypotension in a patient, so that favors aldosterone deficiency. The sugar is less in the body of this patient, that is because of cortisol deficiency. If cortisol is less in the body of this patient, then due to cortisol deficiency in this patient, there would be a development of hypoglycemia. The blood sugar of this patient would be significantly reduced. So this tells me the fact that the patient is having Addison disease, and now I need to work out whether it's primary or secondary. The point is that there is visible hyperpigmentation of the palmar and the sole creases in the patient with some hyperpigmentation involving the tongue also. Now, this is a dark patient. Indian patients will be dark, but some amount of hyperpigmentation can definitely be seen. Because hyperpigmentation is present in this patient, this tells me the fact that in this particular case, the clinical diagnosis of the patient will be primary Addison disease, because the gland is damaged in the patient, because hyperpigmentation is present. Now we need to evaluate, since it's an accept question, which of the following is not a cause of primary Addison disease. Histoplasmosis can damage the gland. The most common cause of Addison disease is autoimmunity, TB, histoplasmosis, amyloidosis. So these two can cause destruction of the gland. Autoimmune polyglandular syndrome, the name itself tells you, autoimmune polyglandular. So Addison disease could be present. In this condition, even concomitant hypoparathyroidism could be present. So you could have a combination of Addison disease with hypoparathyroidism. Autoimmune hypophysitis. CRS deficiency will cause deficiency of ACTH, and that will cause decrease in the value of cortisol alone in the blood, because ACTH acts only on the second layer of the gland. Point is that why C cannot be a answer to this particular patient is because in ACTH deficiency there will be absence of hyperpigmentation, and in hypophyseal, that is hypothalamic involvement, there is only cortisol deficiency, whereas in this condition both hormones are lesser. So the correct answer to this question is C. You see, the concept in this question is based on the fact that whether you can differentiate between primary and secondary Addison disease, and clinically hyperpigmentation is a feature of primary Addison disease. If hypothalamus is involved, then that causes tertiary Addison disease. So choice C of this MCQ is causing tertiary Addison disease, whereas choice number A, B and D, they are causes of a primary Addison disease in a patient where gland itself is damaged, and in tertiary Addison disease it is hypothalamus, and secondary it is pituitary damage. So answer is C to this question. Okay guys, this time we shall be talking about image based questions related to the kidney topic and a couple of miscellaneous topics. This is a repeat from the AIMS exam. The question said which urine crystals are shown here. So you can see that these are envelope shaped crystals, very characteristic shape, envelope shaped crystals. Envelope shaped crystals are a feature that are encountered in patients who are having calcium oxalate. These patients could be having kidney stones, and calcium oxalate is the most common variety of kidney stone. The most common cause for calcium oxalate stone. This is the shape of the crystal that you should be aware of. The most common cause for calcium oxalate stone. The most common cause for the commonest stone is idiopathic hypercalciuria. These patients have a tendency to have more calcium excreted in their urine. Therefore, for diagnosis of this condition, we shall be doing a 24-hour urinary calcium. And because 24-hour urinary calcium is increased in these patients, therefore, for management purposes in these patients, you would be telling these patients to take normal calcium diet, normal vitamin D in the diet, but they would be simultaneously advised to take thiazide diuretics. Why thiazides? Because thiazides tend to reduce the calcium loss in the urine of the patient. Uric acid crystals will not have any finite shape because the crystals are very soft. Calcium phosphate crystals, they will have a rosette shape. So rosette shaped crystals are calcium phosphate, and histine stones would be having hexagonal shape. I'll draw that again, hexagonal shape. So if you find hexagonal crystals, then it is going to be cystine, and rosette shaped is calcium phosphate. Do not mix calcium phosphate with triple phosphate. Triple phosphate is the one which will have a coffin lid appearance, but calcium phosphate is the one which will be having a rosette appearance. Calcium phosphate stones are seen with hyperparathyroidism or hypoparathyroidism, and triple phosphate is due to protease bacteria. This is the shape of the crystals shown once again. Coffin lid appearance. Coffin lid appearance is very characteristic for triple phosphate stones. Hexagonal for cystine stones, and rosette shape, as I mentioned, is for crystals of calcium phosphate. What does the following angiogram in a hypertension patient show? You can notice this chain of beads appearance in the renal artery of the patient. This chain of beads appearance that is present in the renal artery of the patient on renal angiography is diagnostic of fibromuscular dysplasia. This is like a rosary bead or chain of bead appearance in the renal angiography report of the patient. Atherosclerosis will cause a uniform narrowing of the artery. Takayasu will cause ostial narrowing. So answer why not it is B is because there would be uniform narrowing of the artery, not like this chain of bead appearance. And Takayasu will cause ostial narrowing. It's very difficult to diagnose on even angiography because it's only ostial narrowing. So that's always a diagnosis of exclusion. This is the cause of renal artery stenosis in young people. Why would you have renal artery stenosis in a young female? The cause would be fibromuscular dysplasia. If the question mentions an adult, he mentions a smoker, or he mentions patient's age to be usually in excess of 60, then the cause to be thought of is atherosclerosis. So in old age, it is atherosclerosis. In young female, it is fibromuscular dysplasia. For India, it is controversy slightly. That would be non-specific arteritis and then Takayasu's arteritis. You see, in India, there are no validated clinical studies, so that's why there is a reason for a controversy. Takayasu's arteritis and non-specific arteritis are two important entries. First one is non-specific arteritis. You can see big cysts in the kidney. This is having loss of corticomedullary differentiation. So because of the fact that there are multiple cysts in the kidney and the corticomedullary differentiation is lost. Therefore, this is gonna be answered by you as a polycystic kidney. One of the main highlights of polycystic kidney would be loss of corticomedullary differentiation. And the kidneys shown in this patient are from a 24-year-old man. And what could be the most likely cause of his death? Then the most common cause of death in autosomal dominant polycystic kidney. The most common cause of death in autosomal polycystic kidney disease should be answered as hypertension. A reference is Harrison. I agree that some guides and some teachers are mentioning regarding subarachnoid hemorrhage and some people mentioning renal failure, but the current 19th edition of Harrison clearly mentions the fact that it is hypertension based complications. So we'll go by the standard textbook reference that the leading cause for death in autosomal dominant polycystic kidney disease is hypertension. A patient is scheduled for hemodialysis. What is the AV fistula shown below called? This fistula for hemodialysis is known as Semino-Brescia fistula. This is in name of that Italian doctor who first time created this fistula, Semino-Brescia fistula. And this would connect the artery to the vein and you hook this up to the hemodialysis machine. Hemodialysis is done when the glomerular filtration rate of the patient will be less than 30 ml per minute. 1.73 meters square of body surface area. That is when hemodialysis is done in a patient. And if the value of the GFR goes to less than 15 ml per minute, 1.73 meters square of body surface area, then the treatment of choice for the patient will be allogenic kidney transplantation, because that would be ESRD, end stage renal disease in a patient. The following urinary bladder on MCU is diagnostic of. You can see this abnormal serrations which are originating from the bladder. These are bladder diverticula which are formed due to increased pressure in the bladder. The reason for formation of this bladder diverticula is a neurogenic bladder. So the answer to this question would be given as B. This is also known as a Christmas tree appearance. Christmas tree appearance on micturating cystourethropy. Christmas tree appearance on a micturating cystourethropy is diagnostic of a neurogenic bladder. All are true about the condition shown except cysts at the junction. So this CT scan will be, this is kidney having all these cysts, huge kidney mass with all these cysts which are present. So the image here shows autosomal dominant CT scan showing huge cysts in both the kidneys. It is autosomal dominant polycystic kidney disease. This is the pancreas. In these patients, they can even be pancreatic cysts. And then you're having huge cysts in the kidney. Some part of the liver cyst can also be seen. So, even if the cut section shows some part of the liver, then they can be liver cyst in these patients. So the question says that there are cysts at the junction of distal tubule and collecting duct. Okay, I mean cysts are present involving the kidney structure. Spider leg appearance can be seen in the patient. Spider leg appearance is a feature that is seen with respect to autosomal dominant polycystic kidney disease. Anemia because of damage to the kidney of the patient, and low renin due to pressure atrophy. No, it's always a high renin condition. Autosomal polycystic kidney disease will always result in high renin. So the correct answer to this question is delta. Reason why it's not low renin, no, whenever GFR of the patient will reduce due to damage to the kidney, the values of renin will rise, and when renin will rise, it will result in development of hypertension in the patient. The most common symptom of ADPKD is flank pain, followed by development of increased incidence of UTI in the patient, and then hypertension in the patient. So this is a condition causing a higher renin hypertension. Spider leg appearance is a feature that would be seen on intravenous pyelography for polycystic kidney. Which tongue appearance is shown here, then this is a magnetar tongue. Lot of guys, they casually answered a strawberry tongue, but this is a magnetar tongue. You can see the color of the tongue is purplish, and this is due to vitamin B2 deficiency. So it is B2 deficiency which is responsible for magnetar tongue. For the diagnosis, if you look at the manifestations in the first figure, you can see bulbar congestion, fever for 5 days. That's again a hint, fever for 5 days. Then there is bulbar congestion present in the patient. The second feature that is present here is you can notice here desquamation. There is a periungual desquamation occurring. Periungual peeling of the skin is seen. There is a periungual peeling of the skin. I can mention it here. Peeling of the skin is occurring. Peeling of the skin is a feature that is always seen with respect to patients who are having Kawasaki disease. Then you can see cervical lymphadenopathy, unilateral cervical lymphadenopathy. Then you can notice strawberry tongue. So considering all the possibilities in the question, the correct diagnosis of this question is alpha. Scarlet fever will show a rash which is all over the body, and there would be bilateral lymphadenopathy in scarlet fever. Here there's a unilateral lymphadenopathy, so pretty straightforward our diagnosis. A child presents with the following appearance, that is seborrheic dermatitis, hepatosplenomegaly, pancytopenia. Well, the initial presentation would make it sound like the child is having a blood cancer, but then if you look at the skull of the patient, you can see these huge craters which are formed here, these craters in the skull of the patient. So these craters which are formed here, this would be called as a geographical skull. This would be called as a geographical skull. And whenever you read about this statement, geographical skull, the disease which has to come to your mind is histiocytosis X. You can also notice the unilateral proptosis in the patient, that is also seen with histiocytosis X. Initially, when I looked at the theory, it looked like a blood cancer, hepatosplenomegaly, pancytopenia. In a late presentation, it could have been myelofibrosis, for example. But then, because the question was mentioning information of X-ray skull, and there's a geographical skull, so the diagnosis is okay. So the diagnosis is geographical skull. This would be a clinical presentation of what we study as histiocytosis X. Pepper pot skull is a feature that is seen with respect to hyperparathyroidism. Hair on end appearance is thalassemia. This is hyperparathyroidism. Hair on end appearance, this is a feature that is seen with thalassemia. And with such an extreme presentation in the patient with unilateral proptosis, seborrheic dermatitis, hepatosplenomegaly, and pancytopenia, this is definitely not artifacts in the skull, so there is something sinister. I can just put it like this, that if you get an X-ray skull, there can only be three possibilities in a question. Either it would be lattice punched out lesions of multiple myeloma, or it would be hair on end appearance, or it would be geographical skull. Geographical skull is a feature that is always seen with histiocytosis X. A 65-year-old rickshaw puller has presented with development of lump in the left supraclavicular area, so fairly a big lump here. This is the left clavicle of the patient. This is how it will be, the left clavicle of the patient. And there's a lump in the left supraclavicular area, so I am gonna call it Virchow's node, or I'm gonna call it Troiser sign. The swelling is about 10 to 5 centimeter, firm in consistency, non-mobile, which like cancer is most likely to metastasize to this area. So it would be GI malignancies, that would be carcinoma stomach is most likely to metastasize. This would be a Troiser sign in the patient, and carcinoma GI malignancies are usually responsible in testicular cancer. Here it's written CA penis, not CA testis. So that's the point why CA penis has been ruled out. CA penis goes to inguinal lymph nodes. Identify the condition. They give an image like this. You can notice a big cystic sac present here. This big cystic sac, this is a diagnostic of myelomeningocele, which is a neural tube defect which is seen and is causing flaccid paralysis of the legs of the patient, can be associated with Arnold-Chiari malformation. There is no mention of myelomeningocele in the MCQ, so on careful reading you will call this the spina bifida aperta. Spina bifida aperta is a term which encompasses two things, that is myelomeningocele and second would be meningocele. These are two features which are to be remembered for spina bifida aperta. Craniorastasis, choice number C, is the most severe neural tube defect. Craniorastasis is the most severe neural tube defect. It is a combination of two things. In craniorastasis, you will be having anencephaly, and the second feature that is seen is myelomeningocele. These are two complications which are seen with craniorastasis. This is a manifestation of craniorastasis. This is the most severe neural tube defect. It is a combination of anencephaly plus myelomeningocele. At anencephaly, there is a cranial word missing, so this is anywhere ruled out. A choice of the MCQ, sacrococcygeal teratoma, that will present with a solid mass and that will be originating much more lower. So this is a cystic swelling at the back at the lumbosacral spine, so that's why the answer is myelomeningocele. This is again an image that shows encephalocele. There's a swelling at the back of the head of the child. This is again a neural tube defect and the child will die not because of any infection but because of raised HCT. Nursing is to be done in prone position. You can already see the atrophy of the skin developing and this could be resulting in even rupture of the lesion and intracranial hemorrhage. Lemon sign in Arnold-Chiari malformation, just shown here because it was asked. Lemon sign is seen in AC malformation. Arnold-Chiari malformation from internal medicine to be remembered is Arnold-Chiari malformation type 1. There are four types of Arnold-Chiari malformation. Type 1 Arnold-Chiari malformation is the one which is responsible for development of pharyngomelia. Whereas Arnold-Chiari malformation type 2 is the one which is responsible for development of congenital hydrocephalus. I repeat again, there are four types. 3 and 4 are not compatible with life. 3 and 4 are not compatible with life. For type 1, I'll mention again. A bit of writing issues, I would say. Arnold-Chiari malformation type 1 is associated with pharyngomelia, where you have dilatation of the central canal of the spinal cord. And Arnold-Chiari malformation type 2 is associated with the development of congenital hydrocephalus. Frog eye sign is again a question asked. Frog eye sign is seen in, that is anencephaly. So neural tube defects were asked. Folic acid deficiency. Mostly in internal medicine, we find that if a woman is using antiepileptic drugs, then valproate and all other antiepileptic drugs, they can cause folic acid deficiency and therefore they can be a development of neural tube defects in the baby in future. The safest antiepileptic drug in pregnancy is lamotrigine. That will have the least incidence of development of neural tube defects. These were a couple of miscellaneous questions that you need to remember. Next are a couple of slides from clinical hematology. One, in this image, I would like you to specially pay attention to the prominent cheeks of the patient. You can look at the nostrils of the patient. They look like animals. Our nostrils are pointing downwards. I can just bring it to focus again. If you look here, the nostrils, the image, in fact, look at again. One, I would like to point towards the pointed incisal teeth of the patient. You can look again, the teeth of the patient. Then you can notice the nostrils which are